He was the first to do a CT-guided abscess drainage ever in the world. He was the first to do a CT localizing scan in the world, which is a precursor of our topogram scout view in CT. Like, this is amazing. He also did the first radiation dose reduction for CT biopsy. People back in the 70s were not thinking about CT reduction of radiation back at the time. I remember this as a resident in my time. He was the first to use fibrinolytic drugs to improve abscess drainage. I remember being on service with him, being on call with him, and we had to put a catheter in, and then you would have to put urokinase in the catheter. He had different approaches to abscess drainages that nobody else had, transrectal. You know, he talked last night about putting a needle in between the IVC and the aorta and moving the bevel a certain way so that you didn't go into the aorta, but you got to the pancreas, right? You know, he just had this finesse in the way he practiced medicine.
No complications.
He was the first one to inject gas to move structures for prevention of damage during biopsies. He did, you know, that's a way to dissect as you're biopsying. I use this now in breast imaging where I am with lidocaine or air at times to move vessels and things out of the way so you don't do harm to the patient or you reduce the harm that you're doing to patients. He did the first de novo percutaneous removal of a gallstone. He did the first CT-guided RF ablation of a celiac plexus in a patient with pancreatic cancer to relieve the severe abdominal pain caused by that cancer. It was targeted surgery without surgery. That was targeted treatment without side effects. And he was absolutely a man before his time, and he pushed us as a practice, as a subspecialty into the future. And I always enjoyed running into him in the hallway, doing, you know, as a resident, being this training, because he would just concentrate on the images we were reviewing. He would talk about the dreams of what he envisioned our radiology practice being in the future. It's always great to hear the excitement in his voice. He's always been a lifetime learner, and that's something that I have learned from him and carried on through my career. He has mentored so many people and established a legacy across the United States of people that he has trained and mentored that has impacted radiology across not only the United States, but the world. Because of this, he has received multiple awards, such as the gold medal from the American Rank and Race Society, gold medal from the SCDC MRI Society, lifetime distinguished teaching award here in our department. He's been an opening speaker at the Swedish Radiological Society. He's been the keynote speaker at Uppsala, I hope I'm
Uppsala.
that correct, Uppsala in Sweden. He's a fellow of the Swedish Radiological Society. It was the first fellowship ever awarded by SRS. He was given, he became a fellow of the American College of Radiology. He also was a board examiner for the American Board of Radiology during the times that are recurring again of oral awards. He was the chair of our department. He was a surveyor at Medical Education Association. He was a tenured professor here at Case Western Reserve University, one of the youngest tenures awarded at the age of 36. I could sit up here and read his CV, but I think I've gotten my point across. So it is my honor to be here today for the first annual John Mark Haaga and Sven-Ivar Seldinger Interventional Radiology Lectureship in memory of Beth Haaga, who was John's daughter who passed from kidney cancer, but I'll let you talk about that. And I'm going to let John come up and say a few words, and then I can introduce our guest speaker today.
Well, thank you very much, and I need to say that Donna is a wonderful physician. She's been really terrific working with everyone, so I'm really, really glad that she's doing it. So anyway, I want to look forward to everyone coming and appreciate it. We have a wonderful lecturer, Hooman Yarmohammadi. He's an interesting person, very smart. So he'll be giving a lecture today. Want to put him up here and start the process, and we'll see how good he really is.
Thank you, Dr. Haaga.
Our guest speaker today graduated from medical school in Iran from the Shiraz University of Medical Sciences. In between that and his residency here at the university hospitals, he had multiple his internship, he had multiple years of research, but he really was an outstanding resident here and was chief resident here when he was with us. He then left here and went to do his fellowship at Johns Hopkins Medical Center in Interventional Radiology. He is now an assistant professor of radiology at Cornell University. He's an associate attending radiologist at Memorial Sloan Kettering Cancer Center in the Department of Radiology. He is a committee member of the LIRADS Treatment Response Working Group at RSNA. He is a committee member of Econ Akron Cancer Research Group. He's director of research and interventional radiology at Memorial Sloan Kettering. He's the Committee of the Society of Interventional Oncology. He is active in over 15 trials and has over 100% research funding currently, and working on R1 grants as well. He has over 100 peer-reviewed articles in both chapters, and today he's going to talk to us about anti-glycolytic therapies in hepatobiliary and pancreatic cancer, transitional and clinical trials.
Well, hello everyone, and thank you so much for the introduction. Thank you, Dr. Haaga. I'm very humbled and honored to be here. And let me see how this works. How can I advance the things, the slides with? Okay, there you go. So today I'm going to be talking about anti-glycolytic therapies. And these are my disclosures. So when we're talking about hepatobiliary, we're talking about mainly HCC and cholangiocarcinoma, but I'm going to be focusing only on HCC today. And as you guys know, it's a very deadly cancer. Curative options are liver transplant, resection, ablation, and most recently radiation segmentectomy. But only a small portion of these patients are candidate for that. So for the rest of them, we offer intra-arterial therapies, which are bland embolization, chemoembolization, radioembolization, and arterial infusion. And my focus will be these two, bland and TACE. The reason we can get away with not necrosing the whole entire liver after embolization is because 75% of the blood supply to the normal liver comes from a portal vein, and but the tumor fortunately relies mainly on the hepatic artery. So once we go and block the hepatic artery, we cause hypoxia and also hypoglycemia in the tumor, and we cause tumor necrosis, mainly relying on this hypoxia. And when you cause hypoxia, you're blocking the aerobic metabolism. That means you're blocking that Krebs cycle. And then they saw in vitro studies, hypoxia, a lot of cancer cells, it does stop their growth, and including HCC, you can see cell cycle arrest. And so it's helpful. Obviously, we've done it in clinical trials, and we've got 24 months overall survival and long progression-free survival, but it's not enough, and they recur. A lot of them recur, especially the ones that are bigger, and you have a latency period. So after a while, 1 year, you get cancer is back. And the studies that we've done on tissues that were available, like post-transplant, post-resection, you see only a limited number of them show extensive necrosis. So you have viable tissue. Basically, they're all located around the tumor, and it's because they still get the blood supply from the portal vein, and there's a lot of collaterals. That also helps, and so you have residual tumor. And you can also see this more prominent when you're doing a repeat embolization. So the first one, you might be successful. The second one, you're less successful. And it seems that HCC is becoming it's becoming resistant, or it already is ready for that hypoxia and it's already adapted to it. So there is a need for more aggressive treatment options. And the way we can understand this better is by understanding the microenvironment of the tumor and by understanding how the tumor is working. So this goes back to the metabolism and how it gets adapted to hypoxia. So HCC, we know it grows on a platform of cirrhosis. And cirrhosis already causes hypoxia. So HCC from the beginning, it's getting ready and familiar with hypoxia. And once you have a hypoxic environment, they have increased production of this HIF, which is a hypoxia-induced factor. And when there is normal oxygen environment, this component of HIF, the HIF-1 alpha, it degrades. But when there is no oxygen and it's hypoxia, it stays active, combines with the other part, and starts producing and expressing and overexpressing different stuff that would help the cancer cell to survive. So one of them that it overexpresses all the enzymes that are involved in glycolysis. And also it upregulates the transporters, so more glucose goes into the cell, and also active glycolysis, and it starts producing lactic acid. And lactic acid is the poison that the cancer cells have. It keeps producing it and it pumps it out. So it doesn't want to keep it to themselves. They want to spread it outside, and once it's outside, it does immunocompromise, the immunosuppress the cells around it, and it helps with metastasis, and it also causes resistance to treatment. So we have to figure out a way to block glycolysis and to block this perfusion of lactic acid. And when we also look into different types of histologies in HCC, we see the more aggressive the type, the more poorly differentiated, the more it relies on glycolysis, and the worse the prognosis, the more invasion of the vein and portal vein. So it seems that, in summary, it seems that HCC is already prepared for hypoxia. So you're dealing with a cancer that is ready for your treatment. And it's ready because of that HIF factor and because of the angiogenesis that this HIF factor does. So it gets more vessels, more supply. It upregulates glycolysis, so it's not really relying on your oxygen that you're cutting it out. And also it has a lot of lactic acid ready to go. And what is glycolysis? Well, it was first described by this guy. He's a German genius that won the Nobel Prize in 1956. He explained this process, and it was the shift of metabolism from oxidative phosphorylation to glycolysis in cancer cells. So here you see the normal cell, and normal cell uses pyruvate and forms acetyl-CoA. Then it goes into the mitochondria, and it goes to the Krebs cycle, and it gives you 36 ATP. And then when you don't have oxygen, normal cells go through, the pyruvate goes to lactic. And that's like when you're running, you don't have enough oxygen, you're not you're not in good shape, and then you get lactic acid. And that doesn't produce that much energy. So it's not an efficient way, but it's only, the body only relies on it when, temporarily when there's no oxygen. And you call it anaerobic glycolysis because it happens when there's no oxygen. But cancer cells, they don't even go that path. They don't try, they shift everything toward producing lactate. And they do that even when there's oxygen available. That's why they call it aerobic glycolysis or the Warburg effect. And it produces a very small amount of energy, but it's so efficient and it does that 100 times faster than the normal cell. That's why you get huge amount of energy. And that's why when you compare it to normal cell, you see that the cancer cell doesn't really need the oxygen, and it's relying 50 to 70% of its energy on this phenomena. So back to what we do. Bland embolization, chemoembolization, we cause hypoxia, hypoglycemia, tumor necrosis, correct? But at the same time that we do that, we're causing increase in HIF, and we're also causing more glycolysis. So, and also, the other thing that cancer cell does is overexpression of this carbonic anhydrase, which pumps out the lactate. As you can see, because cancer cells, once they are producing this lactate, and the intracellular pH will go down, and it blocks the glycolysis because the enzymes that are involved in glycolysis are very sensitive to the pH. So it needs that perfect pH, and in order to have that, it needs these anhydrase to pump out the extra acid and bring in bicarb. And so this is one of the mechanisms. It's like a snake biting itself. You produce this poison, but it has to go out, can't stay in. In summary, so we have increased glycolysis after embolization, you got increased angiogenesis, and you got lactic acid there. And so looks like this hypoxia has a double role. At the same time that it's causing some necrosis in some of them, it is causing tumor survival. That's a picture I took when I was at my MSK. So seems like we need to help this local regional therapy, and one of the good targets looks like this glycolysis. So there has been a lot of drugs that have been developed, and main question, why don't we hear it like more frequent? Well, it's because these drugs are not so strong and not effective enough when they're being used by themselves. Once you increase the dose to a level that is now effective by itself, it becomes toxic. So you get really good results in vitro and in vivo, but you can't translate that into clinical trials. And so that's when IR comes in. We do local regional treatment. That means we can inject higher doses. The toxic dose now remains safe, and we can inject it inside the tumor directly. So the two types of two big classes of anti-glycolytic drugs are those that block the glucose uptake, and the second one are those that target different enzymes. This is the big list of all of them. In green are all the drugs, and in red are all the enzymes that they block. And as you can see, there's a huge amount of these drugs. And the one of them that blocks glucose uptake is ritonavir. And I thought it's very interesting because it's the drug that now we're using. They start using it for treating HIV, but then now they use it for Paxlovid. And for those that got COVID after Paxlovid, you guys know how Paxlovid is amazing. So it just blocks this GLUT4, and it has been useful with melanoma, breast, ovarian cancer, cell lines, but not with HCC. And again, monotherapy was not that significant. So the next category is the ones that block the enzymes. And these are all the different enzymes that have been blocked, and these are the drugs that have been blocked. And I'm going to go over those that have been used with HCC. So the first one is the 2-DG, and it blocks hexose kinase. It has been used with HCC, prostate, and cerebral glioma. Again, monotherapy, like all of them, not so successful. And once you increase the dose, they get hypoglycemic. So the main usage would be combination therapy. And when they combined it with external beam radiation, they got good results, and that was that they figured out that this is a good radiosensitizer. So they used it to treat GBM and anaplastic astrocytoma, and the oral dose, once a week with external beam radiation, they gave them really good responses, enhancement of the tumor necrosis, and it was actually protective to the normal brain. So this was, then we used this and we figured out that maybe we should test this in combining with radioembolization, one of the local regional options that we have. So now this is an ongoing preclinical study that I'm working on, that we form HCC in oncopig animal model. We have two arms. One arm we're using oral dose of this, and the second one is intra-arterial, and then we're going to treat the tumor with TheraSphere. So in regards to the oncopig model, this is our lab, and we got a fluoro CT scan there, and an operating room right next to the fluoro in case you need to operate on an animal model and then transfer them to the fluoro unit. And the way we develop this tumor is on these oncopig, which are transgenic mutated pigs with two mutations, KRAS and P53. And you all know that these are the two of the strongest mutations. So both of them combined together, these pigs will develop the tumor in a week. And that's what you want from an animal model. You can't wait a month for a pig to grow a tumor. You're gonna go broke because you gotta keep feeding the pig. So you want to get the tumor model very fast, and this gives you that. 1 week you get a 3 centimeter tumor, which is perfect. And then the other good thing about pig model is that it has a similar size, physiology, drug dosing, and also immune response to human. Unlike the mice and rat that are very different, this is very similar. So we use the same catheter that we use for embolization in human, and we use it in these pigs. The way you have to form the tumor is you take a sample or a core of that organ you want the cancer. Like this is an example of the pancreas. This is a pig's pancreas, and we have our needle in it. We take a core out, then you induce it by a virus, and then you inject it back in. And this is for HCC, that you inject the liver tumor that is now induced into the liver, and you get HCC. So this is a really good model. It has its limitation, including it's not on a platform of cirrhosis. So it's not exactly like the human's HCC, but it's hypervascular, and it forms these nice vessels, so you can catheterize them and embolize them. So this is the model that we have been used, and you get the pathological findings and histological findings are very similar to human HCC. And we're going to be using this. We're using it with this model, the 2DG plus radioembolization. The second drug is DCA, and this drug blocks pyruvate dehydrogenase kinase. By blocking that, it kind of pushes the cancer cell to go back to the Krebs cycle. So the cancer cell that is now relying, largely on Wahlberg effect, you cut off that, and that's how the tumor cells get killed. Again, like the rest of these anti-glycolytic, monotherapy is not helpful, so we combine it with sorafenib, and you see when we're in HCC, you see better results. And if you combine it with doxy, which is one of the main chemotherapy drugs they use in DEPTase, you also see enhancement of this effect. So the study that they did comparing DCA plus doxy shows that the tumor growth and the volume is significantly lower when you have them combined compared to either one of them by themselves. And the interesting thing is, see, the anti-glycolytic drug by itself is weaker than the options we have available. But once you combine it with things we have, you get a better result. And this is another study that we're trying to do. We're still at the phase of making our particles more efficient. And again, we're going to use the oncopig model, and we're going to combine lenvatinib, which is a newer generation of sorafenib, with doxy, and see how it works. And the particles that are available to us right now and are FDA approved, it's basically DEPTase. And these deptase particles, unfortunately, they have this limitation that they can only put positive charge drugs on them, like doxorubicin, which is positive charge. Irinotecan, but you can't put on negative charge drugs or other drugs. But this particle that we have developed, it allows you to put any molecule there, and you can make it in different sizes, and you can also program its release. So if you want it to be released in 6 months, you can do that. If you want to release the drug in 1 week, you can do that. And so we're going to be loading these drugs with DCA on these particles, and then do an embolization to see if we can get better results with HCC. So the third drug is 3-bromopyruvate. This is the drug that has most amount of studying and publication on this, and it is a really strong drug. At the same time, it's really, really toxic. What it does is it's analog to pyruvate, but it's also similar to acetate and lactate, and so it blocks all these different ways of getting energy in the cancer cell. And main drug that it blocks is this GAPHD. This drug is actually one of the main multifunction drugs that the cancer cells use. So by blocking it, you get massive intracellular ATP depletion. It also blocks, it's also transferred by MCT into the cell. And because MCT is overexpressed in cancer cells compared to normal cells, it might act selectively. And I'm saying might because it really doesn't, but in theory, it should. So it's extremely potent, and in vivo and in vitro studies are like amazing. Both in cancer cells and other cancer cells, pretty much any cancer cell, they kill everything. But you can't translate that into the humans because humans are not rats, most of them. And so the strongest non-target, so the problem that it causes is that it leaks out of the cancer cells. It doesn't stay there for a long time. And then once it's out, you get non-target alkylating properties, and you get systemic toxicities. So it is relatively safe when you inject it intraarterially, intratumoral, or you load it on particles. And it has been studied in intraarterial injection with VX2, and in the low dose, very safe, but as soon as you increase the dose, you get toxicity, and if you add embolization to it, then you get liver necrosis. So that didn't go that far, and the results are like, still working on a way to keep it localized into the tumor. The combination again with cisplatin and oxaliplatin was really good and safe when you treated colon cancer, and that's one of the other studies that we're having. We're combining it with these particles and injecting it intraarterially into the tumor. The first 2 pigs that we've done, they did fine, but this is also remains pending what we see. And then the last drug that I'm going to be talking about is bumex or bumetamide. This is the drug that we all love. It's very safe, and it's a diuretic. It has been around since 1983. It's a very, very strong diuretic, so they only use it when they're like nothing else is responding. So in ICU patients that have congestive heart failure, that's the one that they use it, and it's very simple, very cheap. The maximum dose is 10, and it starts immediately as soon as you give inject it to the patient has forms urine, and it leaves the body very fast. It also blocks other transporters, and so they have used it to treat to treat seizure in neonates, and also to treat cystic fibrosis. But the main property of this drug is that it blocks that carbonic anhydrase that I talked about. And we know that cancer cells overexpress it, especially HCC loves to overexpress these. And once it blocks it, is again, that's what I said, it's like you block the poison from leaving the body, leaving the cancer cell, and that's where you get increase the acid, and then you block that enzyme that is most sensitive to changes in pH, and you block glycolysis. It was shown that it is anti-glycolytic in 1977. And so then what we did back here with Dr. Haaga, this is the study that I did when I was a resident here, we injected bumex intraarterially combined with embolization in N1S1 HCC rat model. So we had 14 rats, and then once we treated them, we used ultrasound to measure the volume of the tumor, and after 4 weeks we sacrificed them and did a histopathological evaluation. And as you can see, this is the figure on the growth rate. And here you see the tumor grew 142% in the control group. And then the group that got just the embolization with PVA, they had a tumor volume decrease by 18%. But the one that got combined treatment, they got a decrease by 90%, which is like 72.2% better, which is amazing. And this is the pathological evaluation. You see in the bland plus bumex group, you don't even see a viable tumor. But here in the bland embolization group, you see some viable tumor. And this was how we were able to start this phase 1, phase 2 clinical trial, and was funded by RSNA. We got FDA approval for intraarterial injection of bumex, and calculated dose based on the weight that we use in the rats. And then this phase 1 was to find the maximum tolerable dose and a standard 3x3 design. And we had 3 cohorts, and 9 patients were enrolled, and none of them experienced dose-limiting toxicity. We had 2 adverse events, and the MTD turned out to be 0.04 milligram per kilogram. So we enrolled 20 more patients in phase 2, and in phase 1, we had 100% objective response with a median progression-free survival of 10.6. It's almost double what we have when we just use bland, and the overall survival of 28 months. So we still have to analyze the rest of the patients, and I mean, the numbers might go higher or lower, but we're still working on it. But seems like this thing is working really good. So the last part of my presentation is focused on using same bumex in pancreatic cancer. And as you know, pancreatic cancer is also a very deadly cancer. The main problem we have with pancreatic cancer is it's hypovascular, so you can't get the chemotherapy drug into it. And also depends highly on glycolysis, even more prominent than HCC. It's one of the strongest glycolytic tumors. As you can see, we have all the factors, the HIF, everything else that I explained in HCC, but in addition, it also uses other pathways that are not even related to glycolysis to use them in glycolysis. So it looks like bumex should work here, but the main problem with bumex is that we need to keep it there. With embolization, with HCC, you can embolize and it slow down the washout, but with pancreas, you really can't embolize the pancreas. So we had to figure out a way to be able to keep it around the tumor. And one of the things that I thought of was Lipiodol. Now, Lipiodol loves adenocarcinomas and sticks to them. So that's why it sticks to HCC, and they use it in TACE. So we tested it, and we saw that it also likes adenocarcinoma in pancreas, and it sticks to it. It also has a pH that can form a good emulsion with bumex. So we got our oncopigs, transgenic mutated pigs, and we got pancreatic cancer in them. And then we injected combination of bumex and Lipiodol into these pigs. We also had 3 pigs that we treated them with the standard of care, which is IV gemcitabine, and wanted to see if it gets different results. So lab were checked, and CT scan was done a week after the treatment. And for the control group, again, these tumors grow so fast, you can't keep the pigs around for more than a week. You have to, any study you want to do, as the time that you start, you have to plan for euthanization, otherwise they might die, and if they die, you die. So you gotta be really careful. The vets are way more serious than you can kill humans, but you can't kill pigs. So anyway, so this is the combination of Lepidol and bumex. As you can see, it forms a very nice emulsion, and then this is injected. That's the tumor, that's the artery. Now the other characteristic of this tumor model is that it forms a vessel for itself, and that's angiogenesis that I explained to you. So you might not be able to find the branch that to embolize, but then once you use this model, it makes a branch for itself. So that's one of the very good characteristics of this model. And then, so as I mentioned, we treated, waited 1 week for the treatment group, and the one that would control were obviously was euthanized earlier. This is the gross model, and then these are the results. So the average size of the tumor was 2.5, and the untreated group, they grew 54% in 2 weeks. The IV gemcitabine group also grew, which I think that's because gemcitabine needs more time for it to work. So we might not be able to rely on that result. But the embolized group, it shrunk by 11%. And another way to figure out if this Lepidol is retained by the tumor is to measure the Huntsville unit, and you can see that it retained, and actually after 12 days you had 8% by volume retention, which is very good. And this is the Lepidol that is still in the pancreas of the pig. And then the labs were fine, no evidence of pancreatitis, no other complication, so it was safe. So the final results, we're still analyzing them, but the preliminary results show that we have at least 30% more tumor necrosis in the bumex group. So in conclusion, anti-glycolytic drugs, they appear to be very effective in treating HCC and PDAC. Systemic options, as I mentioned, are not safe when you want to use the effective dose. So intraarterial injection or local regional options are the better options available, and further studies obviously are needed to find out which combination and which doses would help us. And at the end, this is the acknowledge segment, which I want to thank my attendings here. The residency program here, it's an amazing residency program, and you will realize that once you leave here and compare yourself with other programs, and sometimes it might be too late, like in my case. I still regret a lot of things that I could have done here, and a lot of things that I could have learned, a lot of papers I could have submitted. And so I think that this is an important thing to know. I wish somebody would have told me that when I was doing my residency here, so I could have taken advantage of all these resources you have around you. And I would love to also thank my mentors, including Dr. Haaga. Everything I have is started from you, so thank you so much. Your advice it wasn't just in the field of radiology or IR. You helped me be richer with your financial advice. I'm not rich, but I mean richer. My $10 is now 20 because of you. So, and I think that it's an important thing to know when you are a resident, to find a perfect mentor. And what you also need to do is you have to be persistent. I think it took me 4 or 5 months till Dr. Haaga gave me time to go over this project. But you have to continue. Once you find a good mentor, that mentor can change your life. And that's what Dr. Haaga did for me. And I'm very, very appreciative of that. And these are my fundings and our research group back in New York. So thank you. So any questions?
I just have one thing. I don't like the fact you're smarter than I am.
That's impossible, Dr. Haaga. Yes.
So, I had a question, John. Good to see you at dinner last night.
man.
It's great to see you.
Yeah.
So just one quick story about my interactions with John. I've been here now for 14 years, and I've heard lactate so many times in the last 10 years. I had a great story here. Whenever we would have an interview after I'd say, and we needed to fill some time, I said, put him up with John, and he talked about lactate. It was great because the candidate would be blown away. Like, wow, this is amazing. And he would be so gracious with his time, would take up his time and help with our candidates and everything. He's been a mentor to me. He's been a mentor to so many people in the field of interventional radiology. And thank you. It means a lot.
Thank you.
But I also had a question, actually, about the whole, since we're talking lactate.
Yes. Yeah.
So at one point, we talked about going through the vein. Remember this whole discussion? Specifically for pancreatic tumors. You talked about pancreatic malignancies and going intra-arterially. There's a lot of people talking about portal venous approaches to the pancreas because we don't feel the intra-arterial therapies for the reasons you pointed out. It's just not vascular, of going to the portal venous side. So any thoughts about that or any talk about that?
Yeah, so for pancreas, there has been 3 different methods of doing intra-arterial treatments. One of them is injecting directly into the tumor. And even though there's this myth that, you know, you can cause problems, we have seen that when you inject Lipido intratumoral, you don't get that problem. Plus, there's also other reports from different places that they have either incidentally injected Lipido into the tumor or they have planned it and they get the same results. It's safe and it does shrink the tumor. The other method is the method of continuous infusion of chemotherapy drugs like gemcitabine, which there is an ongoing clinical trial. And it started in Japan where they put 2 different catheters. They block one side and then they inject through the other side because pancreas has, you know, a rich circulation. And then they wash it and continuous infusion of gemcitabine inside the tumor. And they have seen, you know, improvement in overall survival, maybe 3 or 4 months, and that's it. The third method is what you're mentioning, and using the portal venous phase. But the main problem with that is that the toxicity goes up when you're trying to do that method, and you get no improvement in the overall survival. So I think that's something that they're still working on it, but we're not there. I think the only one that is right now approved for a clinical trial is putting continuous infusion catheters in.
Have you looked at bumex or any of the other agents with combined with immunotherapy?
No. I'm focused on glycolysis.
Very good.
Okay.
Okay.
There's questions online. Do we have? I have the chat open. There's a comment that says, it's great seeing Dr. Haaga and Dr. Yarmohammadi. It has been too long for both. No questions yet. Okay, thank you. Well, thank you very
Thank you.
much.
Thanks.
Hooman,
Yes.
Just a quick question, actually, you were referring to, what do you feel about, this is a very general, uneducated question about, how is immunotherapy and the interplay of immunotherapy changing the hypoxia microenvironment?
Yes. So the pathway that the immunotherapy is taking is very similar to the anti-glycolytic, because one part, the main part that, I want to go back to this slide. My lactic acid spot, where is it? Did I skip my lactic acid? There you go. So, two main problems with HCC and pancreas cancer is they don't, they're immunosuppressed tumors. They don't express antigens. And so if you don't get that antigen expression, you can't use immunotherapy. With melanoma, it's like an overexpressed tumor. So you see that all these immunotherapy drugs work perfectly. With these two cancers, because of the microenvironment and the other characteristics they have, they don't express that much. But there are different methods of pushing them to express themselves. And this lactate that is involved with the glycolysis, it causes immunosuppression. And once you block it with the glycolysis, you can get more like overregulation. And the immunotherapy portion of treating now the pancreas cancer and HCC is by making them overexpress themselves. So one of the things that you can see when they're treating pancreatic cancer right now, it's like focus on the vaccines. And we just published a paper in Nature. Dr. Velachandra, he came up with this vaccine that it actually makes you overexpress the immune response in pancreas cancer. With HCC, what they do is they've seen that the combination of two different immunotherapy drugs, the PD-1 inhibitors and the PDL4, when you combine them, one of them makes the tumor expose their antigens, and the second one is the one that treats it. So the main problem we had was that exposing and being more antigenic. And so that immunotherapy is what it's doing. A combination of treatment, one exposing, the other one killing it.
Thank you, man. I just, as an old guy here, an old guy, I just wanted to just shout out to Dr. Haaga. And I have to help one Dr. Haaga. Well, I tell you, my favorite, and you are in the presence of a guy who truly are. Dr. Haaga and I were at the Rankin wedding together at a cocktail party just before his gold medal ceremony. And he and I were talking, having a beer. And I could hear out of the corner of my ear about five or six residents. And they were looking at the program. And they were saying, I'm winner at that time. You got a gold medal winner. The time to get there. And I said, actually, I can see sometime the gold medal winner is right there. Dr. Haaga goes, hi guys, how are you? And I look, he was looking at the gold medal winner, and it's right in front of your face. He is a doctor. You are blessed that he died. Thank you, man. Very much, thank you. And you owe me that paper.
I know. Give me 1 week. Yeah, this paper story is we wrote this paper on CAD in all these chest X-rays, and then I wrote the whole thing. It was like I think you just had like maybe one more paragraph, but then we started studying for the board, and I remember Chip telling me like, when are you going to give me this paper? I was like, just give me 1 week, and then now I remember that it's 11 years on 1 week, but I need 1 more week.
Great job.
Thank you. Okay, thank you.
I gotta tell you, I got a paper 3 years ago.
Yeah.
Been turned down. I think it's resubmitted.
Yeah.
Yeah.
Time to resubmit.
Yeah.
Where's my water?
That's great. Nice.
John, you guys gotta stick around for pictures.
Yes.
We have a photographer here.
Okay.
John, how do you stay?